Hey guys, it's Sarah here. In this video, I'm going to be going over EKGs. It's going to be really simple. You're going to be able to understand what's going on, and it's going to go over everything from bundle branches blocks to ST elevations to your simple rhythms. And the reason why I made this lecture is because EKGs is one of those stuff that a lot of people are not proficient in, and a misdiagnosis of something could really be the difference from life and death. So let's get started. This is just a quick medical disclaimer. This video is not meant to diagnose you. It's not meant to treat you. It's not meant for you to use it to decide whether to go to the ER or not. If you're having chest pain or any symptoms, please go to the ER. This is really just for educational purposes to help people to further understand EKGs and learn about it. Before we get into the whole rhythms, etc., we have to understand what an EKG is. An EKG is basically a recording of the heart. It's like you taking a camera and taking a picture of your heart. And instead of just taking a picture of your heart from the front, we like to take a full 3D or a panoramic picture. And that's where the leads come in. We have different leads, which are basically different views of the heart, to be able to see it from all different ways. We don't want to just take a picture of the front because the back could be having a blockage. So we need a whole picture of it. What you're placing is you're placing electrodes. Electrodes are those pads that are going to pick up the electrical signal from the heart, and then it's going to be able to be traced in an EKG form, which is what you see, the squiggles, the lines, the waves, whatever you want to call it. So your standard 12-lead EKG is taking 10 of those electrodes, so 10 of those pads, placing them on the skin, and it's going to measure it from 12 different angles. So as we said, the leads are basically different views of your heart from different angles. So this is basically what it corresponds to. The inferior leads, which is lead 2, 3, AVF, are looking at the inferior surface of the heart. Inferior, works out. Lateral, same thing. It's looking at the lateral walls of the left ventricle. And those are lead 1, AVL, V5, and V6. And you could read through this, and this is really plain memorization in terms of which leads are the septal lead, which leads are the anterior leads. And it's really important to know, because if you're having something happen in ischemia in the septal surface of the heart, then those leads are going to be affect lead V1 and V2. So it's just important to know that memorization. We could also say the type of leads. So the limb leads are the ones that are placed on the arms and the legs. The augmentins are the AVR, AVL, and AVF, and the precordial leads are generally talking about V1, V6, which are placed horizontally across your chest. Concept you need to understand before we get into the actual EKG rhythms is deflection. So deflection is basically whether the wave is moving upwards or downwards off the baseline. So if you look in the picture on the side, you'll see a positive deflection and then a negative deflection. So negative is downwards, positive is upwards from the baseline. And what that is, if you want to really understand it, it's basically imagine your heart electrical activity as like a little wave. It's like a ripple in a pond. So when those waves move towards a specific point in the body where the electrodes are placed, then it's going to be a positive deflection or a spike up. When those waves move away from the electrodes, it's going to have a negative deflection, a spike down. So this slide, you really have to commit to memory. This is going to be your basis in terms of diagnosing something and seeing if it's abnormal or normal. So what you have to realize is that horizontal, so flat axis, is time. Up, vertical, is voltage. So when you're measuring time, you just have to commit to memory that one small little box is 1 millimeter, which is 0.04 seconds. One large box is 5 milliliters, which is 0.2 seconds. So if you times 0.04 times 5, it's 0.2. So just one small box is 0.04 and one large box is 0.02 seconds. And over here, I'm going to tell you what, over here you see I'm circling, that's a large box, and inside, it's too small for me to circle over here, but inside of those little small boxes. Here's something else you have to understand before we there's just a lot of concepts you have to understand before we get into the rhythms, because people like to jump into rhythms like AFib, A-flutter, this, that. But if you don't understand these fundamental concepts, you're not going to understand anything else in terms of the bundle branches or anything else that's going on. And you really have to understand that this is key. So this is why I'm going through a lot of the introduction first, but if you know this, you're welcome to skip over it. So depolarization is the sequence of events during depolarization. So what this is in this slide is is the sequence of events that occur during depolarization of the heart, which is the electrical activation that leads to the actual contraction. So how it works is, as the SA node, as you see in the picture, in the first picture on the right column, is it initiates the heart contraction or the heart depolarization. So how that works is SA node fires, the atrias contract, and that on the EKG is going to be your P wave, as shown over here. The impulse then is going to travel down to your AV node, and it's going to be a brief delayed. And that's why you're going to have this over here called a PR interval, because there's a brief delay over there. The signals then travel via the bundle of His to the Purkinje's fibers. The ventricles depolarize or contract, and that's where you see the QRS wave or QRS complex on the EKG. And this ensures that the blood is ejected out. So in this way, the EKG is going to help detect and monitor cardiac abnormalities, because you're going to see some disruption. If there's anything wrong where this one's firing before that one, you will see it. So after the QRS and the ventricles contract, then you're going to have the ventricles depolarization is going to be complete. Then they're going to relax or repolarize, as you see in the T wave. And the cycle keeps happening over and over again. So the pacemaker cells in the SA node go to the atrium, pass to the AV node, bundle of His, Purkinje fibers, and all this is going to be correlated on the EKG as shown above. Okay, so now we're going to go into access. Access is something a lot of people have difficulty conceptualizing and understanding what it is. Basically, how I like to understand it, in your heart's electricity, like a big arrow traveling through your heart. So the heart axis is basically the direction that this arrow or this electricity arrow is pointing out. So it could be pointing straight, it could be pointing slightly to the left, slightly to the right. Usually something would be, if the arrow is leaning a little bit more to the left, or taking a slight left turn, let's just say, usually that would be from something like left ventricle hypertrophy, because it's bigger and stronger. Or it could be the opposite, heading to the right side because of right ventricle hypertrophy, or blockage, many different reasons. And if someone has extreme axis deviation, that's in these rare cases, usually the arrow is going in like completely far off its normal path. It's going way off its course. So that's usually indicating something happening in the heart. So to describe a heart's electrical axis, we use a measurement scale called degrees. And the normal electrical axis of the heart typically falls within a range of -30 degrees to +90. And that's basically a little bit downward, slightly to the left, just because of the left ventricle dominance, which is in a normal, typical, healthy person. Many different methods to see if something is left axis deviation, right axis, extreme. One method I like to use is the quadrant method. So what you do is you look at the QRS complex in lead 1 and lead AVF. And you can use this chart below. So if in lead 1 it's positive and in lead AVF it's positive, then we say it's normal axis deviation or normal axis. If it's positive in lead 1 and negative in lead AVF, then we like to say it's left axis deviation. And for left axis deviation, it could further be evaluated using lead 2, but we're not going to go into that further. That's using a 3-lead analysis, but I don't really want to confuse you. So basically, I would just use this chart to see lead 1, check if it's negative, as you see in the picture over here, negative, it's going downwards. If this was the isoelectric line, sorry, that wasn't a straight line, but if this is going up, it's positive. Negative, like we spoke about, deflection is going downwards. So if in lead 1 it's positive and it's positive in lead AVF, you have normal axis. Positive and negative would be left axis, etc. And that's basically how you would determine if it's what type of axis it is. So here's just explaining the difference between waves and intervals, because sometimes people don't know that. So what waves are basically is that they're a graphical deflection showing something electrical activity in the heart. For instance, the P wave over here, if you look at this chart, the P wave would signify atrial depolarization, which is contraction. So over here, that's a wave. And so is the T wave. It's signifying something electrical activity in the heart, which in this case, it's T wave is ventricle repolarization. So they're relaxing. And intervals, what intervals are, this over here is a is an interval. Intervals are time. They represent the duration of time. So we have the PR interval, the QTC interval, etc. And these are just time periods, basically. So the waves are events, electrical activity events, and the intervals are time. And this is a good chart to look at to understand what's happening. We're almost done. We're almost going to get into rhythms, but this is really important. J point is basically the junction between the end of the QRS complex and the beginning of the ST segment. And it's really crucial to understand where exactly the J point is, because one of the most significant uses of the J point is diagnosing an MI, a myocardial infarction. So if there's significant elevation of this ST segment above the J point, it can indicate infarction, injury, etc. So it's really quite important to understand where the J point is. So over here we have QR. It's just a little hard to trace it on this, but S, and then this would be the T wave. So this over here is the ST segment. So this tiny little point right over here would be the J point, and I'll show it to you over here because I already colored on that one. This over here is the J point. See how in a normal one this is straight, excuse my drawing, but you see how it's straight? It's on the same thing. Over here, technically this would be straight, but you see how the J point is elevated. So one last thing before we get into the rhythms is just two steps you should know about EKGs. Number one, patient motion. If patient is moving, you're going to have artifacts, as you see in this EKG over here. You can't diagnose somebody based off that. It's artifacts, and it's going to lead to inaccurate interpretations, etc. So you have to make sure the patient is as still as possible. Number two is improper lead placement. If the lead is placed improperly, it could really be misleading, and it could really potentially lead to improper diagnosis, even treatment. So proper lead placement is really crucial for capturing accurate cardiac electrical activity. So here we're going to go through a systematic strategy in terms of interpreting every single EKG. So this is what I like to use, whether I'm looking at an AFib, A-flutter, any different EKG. This is what I go through all these steps. And I'm going to show these steps. I'm going to fill in every single EKG. You're going to see what's different. And then that way you can go through these steps and say, hey, missing this, it's a whatever. So it's really important to have a systematic step and not just look at something and say it's X, and then you could be missing a lot of stuff. So is there a sinus rhythm? What we want is every QRS should have a P in front of it. So number one, when we look at the rate, a normal rate is 60 to 100 beats per minute. If something is over 100 beats per minute, it's called tachycardic, which means a fast heart rate. Something under 60 beats per minute, it's bradycardic, a slow heart rate. And there's two different methods we could do to figure out the heart rate. Number one, you could count the number of QRS complex, count the number in a 6-second strip. So usually the strips will have little lines at the bottom to indicate a 6-second strip. And so you'll count the number of QRS complex and multiply that by 10. So if there are 8 QRS complex, 8 of those complexes times 10, your heart rate would be 80. Or you could use the 300 rule, which I'm not going to go through much right now, but basically it involves counting the number of large squares between two consecutive RR waves, and then dividing 300 by that number, to get the heart rate in beats per minute. So for example, if you had 4 large squares between the R waves, then the heart rate would be 300 divided by 4, which is 75. So those are just different ways to calculate the heart rate. So number one you're going to look at is the heart rate. Number two you're going to look at is the rhythm. And in order to see the rhythm, you're going to look at the distance from R to R. So remember, the Q, R is that big spike, S. So the R is a big spike, and you can measure from 1 to 1 to 1 to 1 and see if it's regular. When you're starting out, you could take a piece of paper and you could make a line by one R, make a line by the next R, see the distance, and then copy that to each of the R's, and then see if it's equally distanced. If it's equally distanced, it's considered irregular. If it's not equally distanced, it's irregular. The next thing we're going to do is look at the P wave. Usually you look at in lead 2, but what we want the P wave to be is round, upright, uniform, and of course before every QRS complex, because that indicates P wave is Atrial contraction, QRS is ventricle. We want atria, ventricle, atria, ventricle. We don't want them by its own. We don't want it without either. So we want a round, upright, uniformed in every single different one. Now we're going to look at the PR interval. So interval is a time period. We want it to be under 0.20 seconds, which is under 5 small boxes. And that's going to be measured from the beginning, from the P wave to the beginning of the QRS complex. And we'll go through that soon when we go into heart blocks. Lastly, you want to look at the QRS complex. That's the ventricle. You want it to be, well, first of all, you want it to be there. Second of all, you want it to be under 0.10 seconds. So let's get started into our rhythms. So here we have a sinus rhythm, and the reason how we know this is because all 5 steps are normal. This is called normal sinus rhythm. Everything is normal. Like we said, the rate is between 60 to 100. Just a disclaimer, when I put these EKGs, obviously there's not much room, so sometimes I'll put like a small one just to show you whatever I'm trying to show you. But in this case, let's say we do the method. We do 1, 2, 3, 4, 5, 6. That's 60 because 6 times 10 is 60. So you have a rate of 60. Perfect. Our rate is normal. Rhythm, here's your R wave. Here's your R wave. You would calculate how many boxes are between this. Is that the same? How many boxes? Same distance. Same distance. So we're good. Rhythm is called regular. Then we look at the P waves. P waves are round, upright, uniformed, and it's before every QRS. So perfect. PR interval would be our PR interval over here, and that is under 0.20 seconds. Then we go into QRS complex. We like them narrow. We don't like it wide, and as we see over here, they're perfectly narrow. They're less than 0.10 seconds. So over here, we have a perfectly good normal sinus rhythm. So next we go on to sinus bradycardia. Same thing, it's sinus rhythm, but it's a slow heart rate. So everything's going to match up, and the only thing that's different is bolded over here. The only thing that you're going to see different is the rate is going to be under 60. So you have 1, 2, 3, 4. Excuse my drawing because this is really hard to draw in here. But that's 4 times 10 is 40. So you have a slow heart rate. Otherwise, everything is normal because your distance, which is your rhythm, R to R, is the same between each one. Your P waves are round, upright, uniform before every QRS. Your PR interval is perfect. It's less than 0.20 seconds. And your QRS complex is narrow, under 0.10 seconds. So that's perfect. It's just bradycardic. It's a little slow, but it's a normal sinus. So sinus tachy, same thing. I'm not going to go through each one, but in essence, you would go through each one. Everything's the same, except for the heart rate would be over 100. So you would count those waves, and you would times it by 10, and it would be over 100. So now we go into sinus arrhythmia. Everything's normal, except for it's irregular. So you have the rate is perfect. It's between 60 to 100. The rhythm, the only difference is with the rhythm. So if I show you over here, when you're calculating the distance, this is a much longer distance than this. And you count the boxes to see that. And so that would make it irregular. So this is sinus arrhythmia because everything else is good. The P waves are uniformed, upright, as you see over here before every QRS. QRS complex is narrow and tight. And the rate is good because you have 1, 2, 3, 4, 5, 6, 7 times 10 is 70. So everything is perfect except for the distance. Here, the same thing, except for there's an arrest, there's a pause. So there's a sudden absence in electrical activity initiated by the SA node. And so the only thing you're going to see different, besides for the pause, as you see over here, your R to R interval is going to be irregular because, as you see, that's way bigger than this. But besides for that, when there is no pause, everything is perfect. You have your P, you have your QRS, everything's perfect. But you just have that sinus arrest, that pause. So those were all sinus rhythms. Now we're going to go into atrial rhythms. So when we talk about atrial rhythms, we're talking about the P wave. That's what we're specifically going to look at. I mean, obviously we're going to go through all our steps, but the P wave is going to be abnormal because atria is P. The P wave on this thing is going to be atrial contraction. So when we go through our steps, the rate could be regular. The thing that's going to be abnormal with the premature atrial complex is going to be an earlier than expected P wave. And it's basically its name, premature, earlier than expected, atrial contraction, which is a P wave. So in a premature or the contraction. Everything's going to be the same. See over here, the P wave is fine, it's good, there's QRS after. P wave is fine, it's good, it's QRS after. But in the one that's early, this is earlier than it should come, the P wave is going to be a little different shape. But otherwise, everything is going to be the regular, and obviously the rhythm is going to be irregular because it's coming earlier. The distance is going to be smaller than it should be, because really it should come somewhere over here, but it came over here instead. So it's a premature atrial complex. So now we go into something known as wandering atrial pacemaker. So wandering, just as its name says, it's going to look all different. The P wave is going to look all different because in a normal typical heart rhythm, the P wave on the EKG is going to have a consistent appearance because it's going to originate from the same location in the atria, SA node. But in a wandering one, the site of origin for the impulse in the atria is going to shift. So it's going to cause the P waves to look very different throughout the tracing because they're coming from different areas in the atria. So you're going to have the rate, rhythm, it could be irregular, but the thing that's going to stick out is going to be your P wave. Your P wave, as you see, is very different in all this. It's going to have 3 different shaped P waves, as you see. There are 3 different shaped P waves. Multifocal atrial tachycardia is going to be the same thing as the wandering in terms of the 3 different shaped P waves, electrical impulse causing atria to move and wander, but it's going to be tachycardic. So the heart rate is going to be over 100. I didn't have enough space to put it, so obviously if you count this, it's not going to be over 100, but really your heart rate's going to be over 100, but over here I'm just showing you it's going to be the same thing, the 3 different P waves, but you're going to have more complexes causing it to be over 100. So atrial flutter, as its name says, you're going to see these fluttering waves, or F waves we call it. So instead of P waves, we call them F waves. And obviously you can't measure PR interval because you can't find the P waves. They're all F waves. They're all sawtooth-shaped waves. And during atrial flutter, the atria is experiencing a re-entry circuit. So the electrical impulses rapidly circle around the atria instead of originating from a single pacemaker site. So this results in that F wave EKG. And typically someone would say about the ratio. So they would say the ratio of F waves to each QRS complex. So they would say like 4 to 1. So that means that there's 4, or here like 1, 2, 3 for every QRS complex. So it would be a 3 to 1 or something like that. That's how they would explain F waves. Atrial fibrillation. With atrial fibrillation, you're going to have multiple impulses occurring within the atrium, and it's going to result in chaotic wave. There's just disorganized atrial activity, chaos there. And what's happening is instead of contracting like this, contract, relax, you're going to have quivering, just quivering. And this could, by the way, increase someone's risk for a stroke because the blood could just remain static in the atria. It's not coming out. It's not all coming out and contracting like it should. So that's why someone with atrial fibrillation would be at risk for blood clots, because when blood stays still, it could clot. But regardless, in terms of what you're going to see on an EKG, you're going to see these small F waves is fibrillating. So it's not going to be sawtooth like the other one, the flutter, atrial flutter. It's going to be a little fibrillating. And just as a side point, if someone has a ventricle response more than 100 beats per minute, it's usually termed AFib with rapid ventricle response, or RVR, or uncontrolled AFib. And that just reflects the body's attempt to compensate for this decreased output by increasing the heart rate. And if someone says a paroxysmal AFib, it means that the episodes last from minutes to days and may spontaneously convert to normal sinus rhythm. Okay, so now we're going to go on to junctional rhythms. So in your typical heartbeat, you want the heartbeat to be initiated from the SA node, or the sino-atrial SA node. But in junctional rhythms, the heartbeat is initiated from the AV node instead, or the atrial ventricular node instead. And this could result in an inverted P wave on the EKG because of the retrograde activation of the atria from the AV junction. The timing of the inverted P wave in relation to the QRS complex could vary. It could appear before, after, or even buried in the QRS complex. So in junctional escape rhythms, you'll have accelerated junctional and junctional tachycardic. And they're all going to be the same thing with the P wave being inverted, but with junctional, you'll have a heart rate of 40 to 60. Accelerated, you'll have a heart rate of 60 to 100. And junctional tachycardic would be the heart rate of 100 to 180. But you're all going to see the same thing in terms of the inverted P wave. Sometimes it could be hidden, like I said, or buried in it. But over here, you'll see the inverted P wave. So now I want to go on to ventricular rhythms. Just a few terms I want you to understand before you go into ventricular rhythms, because you might just hear it and then just understand what it is. So unifocal is that the complex that are abnormal are the same exact shapes. They're all the same shape. If they're multifocal, they'll be different shapes. Bigeminy, which means abnormal complex occurring every second complex. Trigeminy is it's occurring every third complex. Couplet is two PVCs together, and if there's 3 or more PVCs together in a row or a rate of more than 100 beats per minute, it's called a run of VTAC. But we're going to go through each one of the ventricular rhythms now. Okay, so SVT, which stands for Supraventricular Tachycardia. If you break down the word, that's pretty much what it is. Tachycardia is a fast heart rate. Supraventricular means that the origin of the fast heart rate is above the ventricles. Supraventricular, which in other words is basically originating from the atria. So in simple terms, basically SVT is where the heart beats really fast due to abnormal electrical signals originating from the atria. So what you're going to see on the EKG is going to be a really fast heart rate, so usually around 150 to 200 beats per minute, and the P waves are going to be buried. So in that way you could distinguish it between tachycardia and supraventricular tachycardia. So in regular tachycardia you can see the P waves. It's fast, but you can see the P waves, but over here you don't really see P waves. They're buried, so you can't see them. So here is a QRS. QRST, like you don't see the P waves, they're buried in there. Now we go on to premature ventricular complex. So it's the same thing as the premature atrial ones, except for it's the ventricle. So instead of seeing a little P wave earlier than normal, you're going to see a QRS wave because it's the ventricles. QRS is ventricles, P wave is atria. So you're going to have an irregular rhythm because something's earlier, so the distance is going to be not the same. And what you're going to see is a widened QRS complex, and it's usually bizarre in nature. So you see over here, there is a regular P wave, QRS, and then you have a T wave. Over here, much wider this distance, then this is much smaller. So that's just a wide QRS complex that's like bizarre in nature, as you see this. Let me erase it so you can see better. But as you see, this is kind of bizarre compared to your regular QRS complexes you have. And in terms of the P wave, it's going to be regular, except for before the PVC one, it's going to be either absence or it's going to be after the PVC. So in your typical ones on the regular, you're going to have a P wave come, QRS and T, P wave, QRS and T. But the PVC one is going to look very different. Either it's going to be absent or you're going to see it after the PVC. And of course, it's just going to come in randomly, or early, quote unquote. So the R to R is going to be irregular. So what you're really looking for is just a bizarre, widened QRS complex that's coming earlier than it should. Okay, so now we're going to be talking about ventricular rhythms. Specifically, we're going to go through each one. So the hallmark of ventricular rhythms is going to be a widened QRS complex because ventricular depolarization, contraction, is abnormal. So the rate is going to be depending on which one. For instance, if the rate is 20 to 40, it's going to be idioventricular rhythm. The rate is 40 to 100, it's going to be accelerated idioventricular rhythm. And if the rate's over 100, which usually is over 150, it's going to be ventricular. And if the rate's over 100 or typically over 150, it's going to be ventricular tachycardia, also known as VTAC. And so basically, all you're looking for is that widened QRS complex over point 12 seconds. P waves are going to be buried or hidden in the QRS complex, so you're not going to really see them. And depending on the rate, it's what it's going to be called: idioventricular, accelerated ventricular, or ventricular tachycardia. Specifically, ventricular tachycardia, I want to discuss a little more in detail because there's a lot of stuff to discuss about it. So ventricular tachycardia could be categorized into various different types based on the different criteria, like the duration, the morphology, like the shape of the QRS complex, etc. So here's just some stuff that, in case you hear these stuff, you should know about. So monomorphic means that all the QRS complex have the same shape. So if you look over here, all these QRS complex are the same throughout. As opposed to polymorphic, they vary in different shapes. You see there's this one, and then they're all different shapes and sizes. You could also hear sustained or not sustained ventricular tachycardia, or VTach. So sustained just means that the episode lasts longer, like longer than 30 seconds, or requires intervention in order to stabilize it. Non-sustained means brief, less than 30 seconds, and resolves spontaneously. One more thing I want to mention is Torsades Pointe is basically, it's a type of ventricular tachycardia, and the QRS complexes appear to be twisted around the baseline. So that's pretty much why it actually is called that, because Torsades Pointe, I believe it's translation from France, I believe, and it's like twisting around the points. So that's basically how it looks in Torsades Pointe. As you see, it's twisting around the point or the middle. Just so you should know, it's typically associated with, usually you'll see a prolonged QT interval first, and then it will go into that, which is why QT prolongation is important to watch out for, because this rhythm could generate into ventricular fibrillation, which is a life-threatening arrhythmia. So that's why you want to treat it quickly before it goes into VFib or something else. So talking about VFib, now we're up to VFib. VFib is ventricular fibrillation, and you remember by AFib, we were talking about that the atrias were just quivering like that. They weren't effectively pumping out. So over here is the same thing, just with ventricular. So we're talking with the ventricles. So the ventricles of the heart are just fibrillating. They're just quivering. And, this prevents the heart from pumping the blood effectively to the body. So you're going to have a rapid decline in circulation, and it could lead to a cardiac arrest. What you're going to see on the EKG is you're going to see just chaotic. Everything is just going to be chaotic, basically. The rate is going to be rapid and chaotic. There's going to be no P waves, because we're just talking about the ventricles. Remember, atrias is the P waves, ventricles it's a QRS. And the QRS complex is just going to be irregular, different widths, chaotic, as you see over here. There is, in the context of VFib, there's two different types. We have coarse and fine, and that just really refers to the fibrillating waves on the EKG. So coarse is bigger, more discernible, and fine is usually smaller, lower, like amplitude, I guess you would say, and it's usually more advanced stage. So now we go into agonal rhythm. Agonal rhythm is a very slow, irregular, and it's not effective. It's not an effective heart rhythm. If you see this rhythm, usually the person's in really critical condition. It's usually like the last order of some sort of order of the heart rhythm. Agonal rhythm is under 20 beats per minute. So as you see, there's only two complexes here, that's 20. QRS is going to be really wide, as you see, bizarre, and there's going to be no P waves. This is not a good sign. Here's asystole, which is, as we call, a flat line, because that's pretty much what it is. There's no activity in the heart. There's no P waves, because there's no atrial contraction, there's no QRS, there's no even quivering. The heart's not even quivering. It's just nothing. There's no activity. So the person's dead. They're just flatlined. Okay, so those are all like the basic rhythms. Now we're going to go on to a little bit like other stuff like heart blocks, ventricular hypertrophy, and how you identify that on an EKG. So here we're going to be talking about heart blocks. I know there's like a lot of songs and mnemonics and poems or whatever about the heart blocks, but heart block is basically when there's a disruption or a delay in the electrical signal that controls the heartbeat as they move through the electrical pathway. So this, how you're going to see it is you're going to see a slower heart rate. It can even cause the heart to skip beats. And there are different degrees or type of heart blocks, and they're going to be based on the severity of the disruption of the electrical signal. So you're going to have a first degree heart block, second degree heart block, and a third degree heart block, which is also called a complete heart block. In first degree heart block, that's going to be the most mildest form of the heart block. And in the first degree, there's a delay in the electrical signals. They're getting through. The signal's getting from the atria to the ventricle. It's just delayed. So how you're going to see that in EKG is you're going to see a prolonged PR interval. It's more than 0.20 seconds. So usually they're asymptomatic, but all the signals are going through. It's just delayed. So you're just going to see consistent, prolonged PR intervals. In second degree heart block, there's two different types, Mobitz type 1 and Mobitz type 2. Mobitz type 1 is also known as Winky Bath. And in Mobitz type 1, there's going to be progressively delayed until 1 is dropped. So in first degree heart block, you're going to have just long, or prolonged PR interval. In second degree type 1, you're going to have prolonged. It's going to get more prolonged, and then a heartbeat is going to be blocked. So you're going to have a drop of a QRS. And the cycle is going to repeat itself. Prolong, more prolong, another one dropped. And this patients usually will be symptomatic because they're having a slower heart rate, they're going to have dizziness. And then you'll have Mobitz type 2. Mobitz type 2, which is second degree type 2. And that occurs when signals fail to reach the ventricle without the preceding prolonged delay. So there's no prolong, but signals are not getting through to the ventricles. Third degree heart block, which is also complete heart block, it means complete interruption or complete blockage of signals between the atria and the ventricles. So the atria and the ventricles are both beating independently, but independently of each other. So you'll have atrias beats normally and the ventricles are beating much slower, but they're each beating independently. So what you're going to see on an EKG is you're going to see regular P intervals that come consistently at the same time and regular QRS intervals that come at the same time, but completely very independent of each other. So just as a recap, if you see fixed PR intervals, they're the same exact amount throughout first degree heart block. The PR interval getting longer, and then one QRS drop, that's type 1, second degree type 1. If you see missing QRS complex, but it's not getting prolonged, it's just fixed prolonged, that's type 2. If you see P intervals regularly, QRS intervals regularly, but independent of each other, you're going to have type 3. Okay, so here we talk about a pacemaker. A pacemaker, what it is basically an artificial impulse generator, pretty much. How you're going to identify that the person has a pacemaker or that it's pacing is going to be via a vertical mark, so just a line called a spike. And the way you know if it's an atrial pacing or if it's a ventricle pacing or both is by where the spike is. And so over here, you'll have the spike is before the P wave, so it's an atrial pacemaker rhythm. If the spike is before the QRS wave, you're going to have a ventricle pacemaker rhythm. And if you're going to have a spike between both, as you see there's a spike between the P, before the P, and you're going to have the spike by the QRS wave, that's going to be an AV pacemaker, atrial ventricular, so it's going to pace both. So we're almost done. A few more things to know. So we're going to be talking about bundle branch blocks. What a bundle branch block is, it's a partial or total interruption of the heart's electrical impulses in the right or the left branch of the electrical pathway. So this interruption or block, or whatever you want to call it, causes the signals from one ventricle to detour. So basically, one ventricle is going to contract slightly later than the other one. So you want them both atrials contract, ventricles contract, atrial contract, ventricles contract. But over here, you're going to have one ventricle that's going to contract slightly later. So you're going to have one and then the other one. So the signal is going to contract through the healthy branch first, and then it's going to go to the damaged side. If you're looking on an EKG and you're trying to figure out how to tell if it's a bundle branch block, one of the hallmarks is that it's going to be a wide QRS, right? So it has to be a wide QRS, more than 0.12 seconds. Then you're going to look at lead 1. You're going to go to the J point, which we spoke about where that was before. You're going to go one small box back to the QRS. And if it's going to be below the isometric line, it's going to be a left bundle branch block. And if it's going to be above, it's going to be a right bundle branch. So for instance, over here, you have a QRS. If you're going over here from the J point and you're going back one box, as you see, it's above the isoelectric line, so it's going to be a right bundle branch block. As opposed to over here, you're going back one, it's going to be below. So that's going to be a left bundle branch. Just in general, like people like to say bunny ears. Sometimes it looks like bunny ears for bundle branch, but it's not always. That's why you don't want to rely on it, because you don't want to say it's not a bundle branch just because there isn't bunny ears. But a lot of times with, as you see over here, it's like kind of like bunny ears or like an M wave with right bundle branch block, and or you could see like a W wave with left bundle branch block. But you wouldn't want to rely on that just because it's not always consistent. Just because you don't have it doesn't mean there isn't a bundle branch block. So now we go on to left ventricle hypertrophy. So what left ventricle hypertrophy is the left ventricle is hypertrophy, is getting more larger, thickened. And just, think about this like a muscle. The heart is a muscle, right? And when you work out in the gym, your muscles are getting bigger, they're hypertrophy. And if you don't work out, it will be the opposite, atrophy. But in this case, the left ventricle is overworking, just like you would overwork your muscle to make it larger and bigger. The left ventricle is overworked. It shouldn't be overworking, but in this case, it is overworking. And that's why it's getting bigger and it's thickening. And this is going to cause an increase in the voltage of the QRS complex. And because more muscle mass, more electrical activity. So what you're going to see is a taller and deeper ventricle contraction or QRS complex. It's going to be taller and deeper. Because as you remember, time goes this way on an EKG and voltage will go up and down. So in order to diagnose left ventricle hypertrophy, there's many different criteria that could be used. One common one would be, one such way that I like to use is Sokolow line voltage criteria. That's a common one, and what we do is that we measure in lead 1 and lead 5 or 6. If the S wave depth in lead 1 plus the tallest R wave in lead 5 and 6 are more than 35 millimeters, which is basically more than 7 large squares, it will suggest left ventricle hypertrophy. It's like the tallest R wave. So you would find the tallest R wave in lead 5 and 6. You would count how many boxes, how many large squares it would be, and then you would calculate that with the sum of the S wave depth in lead 1, and then if that's greater than 35 millimeters, which is greater than 7 large squares, that would suggest left ventricle hypertrophy. And you can just see over here, I'm not going to calculate it because we're missing, the V1 and all that, but you can just see how tall it is. It's kind of touching the other one, as you see over here. So we're almost done. I just stuck in this chart that I made just because it's really important to know where, like if you're looking at leads 2, 3, and AVF, what region of the heart we're talking about and where blood supply, because we're about to talk about like ST elevations and ischemia and everything. If something's happening, like if there was blockage in the right coronary arteries, you would see EKG changes in lead 2, 3, and AVF. And that's why you have to know where exactly you're looking for and what exactly the relationship is and where we're talking about what blood supply is cut off or what exactly is happening. In terms of reciprocal changes, you may have heard this a lot, that's why I'm bringing it up. It basically means that the part of the heart opposite where the ST elevation is occurring is experiencing abnormal electrical activity in response to the heart attack. So when you would see reciprocal changes, so wherever you see ST elevations and reciprocal leads, you would see ST depressions. And these reciprocal changes, particularly ST depressions, serve as a really highly sensitive indicator of a myocardial infarction. So, they just provide additional evidence of significant cardiac, ischemia. There's a lack of blood supply there. Okay, so one more thing I just want to clarify is that a lot of people will throw around words like ischemia, infarction, etc. They're different, and it's important to know the difference. That's why I made this chart. Ischemia means inadequate blood supply to the heart muscles, as opposed to injury means that there's actually damage to the heart muscles because of this inadequate blood supply. Infarction means that there's actual death of the muscle tissues due to the inadequate blood supply. So it's kind of like a trickle effect. Number one, you have ischemia. There's not enough blood supply to the heart muscle. Because of that, you'll have some damage to the heart muscle, which is injury. You'll have death of the heart muscle tissue, which is an infarction, which is an MI, a myocardial infarction, is what we're talking about. And you'll see different EKG changes, but just so you should know the difference, what you would see in an EKG, if someone has ischemia, you would see ST depressions, which is why ST depressions, you also have to look out for that. ST depressions of 1 millimeter or more, or T-wave inversions in 2 or more continuous leads. For injury, which is damage, that's where you would see your ST elevations of 1 millimeter or more in 2 continuous leads. Infarction, which is the death of a heart tissue. So what happens is that once the infarction is complete, or the MI is complete, the ST segment elevation will return back to its baseline, and T waves will turn back. But the Q waves will be the ones that will stay changed. And so when you're looking at that, that's evidence that tissue damage occurred, or someone has an old MI, because the Q waves will stay abnormal. Okay, so thank you for watching. I hope that explained and kind of dumbed down and you can understand the EKG a little better. Just remember, this is really for educational purposes. This is not to diagnose a patient. This is really just to help you be able to read EKGs. And remember that you always want to look at the patient and take the whole clinical scenario, and when people are not textbooks. Just because you see a bundle branch block does not mean that there's nothing else going on on the patient, and you always want to look at the patient. If the patient is talking to you and the monitor says asystole, you're not going to start CPR. You have to look at your patient and look at the whole scenario, and everyone's individualized, and so you want to take that into consideration. So thank you for watching. If you have any question, please write in the comment section below, and good luck.